Good afternoon, everybody. In fact, mine is more of a theoretical discussion on IVUS-guided optimization of complex PCI. Now, as you have heard the previous speaker, the unseen enemy is always the most fearsome. And the most unseen enemy are the coronaries having calcium, and this is the unseen enemy. Now, PCI of calcified lesions do need more attention because the safety risk is there. It impedes the stent deliverability, and most importantly, as has been shown earlier, it prevents stent expansion. Now, this is what was shown by Dr. Seth previously, that these unexpanded stents we have seen in the past, and then we go on dilating and ultimately rupture the arteries finally. Now, imaging has made a great difference, and I'll be focusing mainly on IVUS. Now, what are the steps to optimize a calcific lesion by IVUS? There are 5 steps. First, do a pre-intervention IVUS. Do a calcium scoring, strategize your debulking strategy, select your stent size, and do a final IVUS. So 2 runs of IVUS are more than enough. So pre-intervention, how do you identify it? It should be brighter than the adventitia. It should be there should be an acoustic shadowing. The leading edge are detected. Thickness is not detected. Revervations cause repeated arcs. Now, what are these revervations? These revervations are starting from the intimal surface, the reverse. One has to differentiate between the revervations due to calcium or due to the transducer. Please do not confuse them as the revervations due to calcium. Now, it has been shown that if the revervations are there, definitely the thickness can also be predicted and is better correlated than with OCT. So, once you get these revervations, you know that you have almost a good amount chunk of calcium. Now, the differentiate between a superficial and the deep calcium. The superficial calcium will have a lot of revervations that you will see, but the deep calcium you will see will be in chunks which will not so much of revervations, and you will not be able to see anything beyond it. So, this is very important to know what is superficial and deep. Based on this, you can strategize what is to be done. Now, calcified nodules are an area which are really very risky in fact, and you have to choose your strategy. And this is what you see on calcium nodule, something protruding inside. And there have been various classification nodule from type 1 to type 5, and these can all be identified on IVUS. Now, the next step would be to score it, and this has already been discussed about how many quadrants of calcium are there. Is it a 1 quadrant, more than 1 quadrant, or more than 3 quadrant? And as I told you, you can also classify it into the superficial and the deep calcium. Now, this calcium score has been hinted upon, and this is from a scoring point from up to 4. Anything more than 2, you need to do it, need to debulk it. First, if it is less than more than 270 and this thing is more than 5 millimeter length, or it is 360 degrees, or if there is a calcium nodule or the vessel diameter less than 3.5, you give each of them 1 mark. And it has been shown that whatever is depending on the degree of calcium, the stent expansion depends. And so there you need to think of an atherectomy. Now, for example, if we take a case, this case shows a 360 degrees calcium, which is 0.1 score, and the length of the calcium is 26 years. So this also merits a 0.1. And the vessel size is more than 3.5, so the score is 0. And finally, it is having a nodular calcium, score is 1. So if you total up, this total score is 3. And please remember, if the score is more than 2, you need to do a good advanced calcium preparation. The third step is to need of debulking strategy and bed preparation. It all depends on whether the calcium is eccentric, concentric, or nodular. In eccentric, calcium, possibly scoring and cutting balloons are more than sufficient. If it is concentric, you need to do a rota or an orbital or a lithotripsy. And with nodular, again the same thing, the rota, orbital, lithotripsy, depending on it. Now, debulking strategies have already been discussed by our previous speakers, and many times you do think that if there is a concentric calcium, what is the need of a rota? Now, we have to know that rota actually just debulks to some extent, does a plaque modification. For example, what you see over here, a plaque modification has been done, and this helps expansion of the artery, obstruction of the calcium, and you can easily see that your stent gets expanded. Now, the fourth step is to select the device size. The device size, you have to see the proximal and the distal length, bookmark them, and see the length between them, and try to see what is a proximal reference, what is a distal reference, and accordingly try to land your stent on a zone which is less than 50% or approximately 40%. Now, this is what you do, the average of the proximal and the distal reference, and then based on that you do a stent sizing. The final thing is post IVUS, Post-stenting IVUS is necessary because you have to see whether your stent is expanded and at least go up to 90% of whatever is the vessel size. This is very important. The proximal expansion you have to calculate, and you see that the stent expansion is almost more than 90%, so that you know that you have done a good job. It is easier to know by an OCT, but an IVUS you can easily calculate and can know it based on your initial IVUS recordings. Similarly, distal expansion, don't think that you can have this proximal and the distal the same. So you have to also see that there is a 90% expansion in the distal area, which will give you an idea that your stent has been expanded, because you make a tapering stent in the long run. For example, here you can see in this case there has been stent under expansion which needs to it, and if you see the stent expansion ratio, this is only 68%. So this needs more work to be done so that you get a good expansion. Sometimes there is eccentric calcium, and when there is eccentric calcium, don't think that you have to go on expanding. As sir was showing, that if you go on expanding, possibly rupture it. Here we take resort to this eccentricity index. This eccentricity index, any eccentricity index less than 0.7 is significant. So try to get an eccentricity index of more than 0.7, and how do you calculate it? This is by the minimal stent diameter versus the maximal stent diameter into this thing, and this is the formula used to see the eccentricity index. So regarding calcium, this thing, what you don't see or you cannot see can lead to disaster. And IVUS does help in managing a calcific lesion in a very calculated manner. Thank you very much for the patient hearing.
Prashant, can you also re-emphasize on the MSs?
Yes, yes.
What sort of MSs do they need to achieve?
Yes. See,
both for, IVUS, because both mid-proximal LAD and left main. I think the latest thoughts around that.
Yes. The MSS has been actually from the studies that we have got from the Korean studies or the other studies, but if you ask me personally, I would try to go for a 90% expansion. But if you get an expansion of around more than 4 in the LAD, I think I consider it as satisfactory. Because you just cannot go on expanding the artery. Well, ultimately, we have been chasing something and we rupture ultimately.
Correct. So we are, again, clearly, we go to 4.5 on OCT, 5.5 on IVUS at least. That's why you saw me chasing a number of 3.82 was dissatisfactory, went up to that. But if you're doing left mains, you're now clear. It used to be 5, 6, 7, 8, which meant 5 for ostia of the circumflex, 6 for ostia of the LAD, 7 for polygon of confluence, and 8 for left main. I mean, those are undersized. You yourself see it, yes, that even a 4 millimeter left main is supposed to be greater than a 10 to 11 millimeter square. So I think you have to understand that we're now aiming clearly for greater than a 6 millimeter circ. And we're talking about the routine cases. You might have a 2.5 millimeter circumflex. We're not talking about that. But in a sense, 6 millimeters, 7 millimeters for the ostia of the LAD, and clearly above 10 millimeters for the left main. And that is what the latest data from the left main trials tells us. In fact, that's what's being studied now in DK Crush 8 study. I think it's that both the ultimate criteria as well as the new sizing.
Yes. Thank you.
Yeah, I was just asked to say whether, there was a question here, and the question related to whether rotational atherectomy, rotablator, burr and wire can be used, or why can't it be reused. Somebody asked me that question, and yes, and I tell you, yes, it can be reused. Hugely reused. In fact, in the initial times when we started rotational atherectomy in 1992, now it's 31 years of my doing rotational atherectomy, and as we had less burrs, and we still were doing 250 rotational atherectomies in the year 1994, which is 29 years ago, 250 a year is what I was doing. I actually rotablated the initial burrs. I actually cleaned them myself, made sure that their inner lumen, because was washed with distilled water and not saline, because we soon realized that the saline precipitates and causes crystals. And I therefore used to measure the time, and each burr used to be used on 3 patients at least, till a burr did a 15-minute total burring time in multiple patients. We won't throw it away. David Oth, my friend who actually invented rotablator, was concerned that he'd never seen a burr being used for 15 minutes because it was never heard that you would actually have to burr for such a long period. And he asked me to show those burrs, and I took them to Seattle, And in the heart technology workshop, they looked at it under electron microscopy. Nothing had happened to the burr. The diamond crystals were still there, only they had got filled up, the grooves had got filled up, so they were getting ineffective. So you can use it as many times, but remember, beyond 5 minutes of burring now in calcified lesions, if we can't get through, we still change a burr because the grooves get filled with debris and the burr becomes smoother. But you can repeatedly use both wires. Wires are more difficult to use because even a small kink will make them not talkable because they're clear stainless steel wires and are poorly talkable wires. Okay? Sorry? Oh no, not at all. So we never found that at all. And I know what you said, higher incidence of complications, no. It's no big deal to reuse burrs, and I would recommend everybody that it's not an implant, so you should be able to reuse it like anything else.
Guys, that was a fantastic session on calcium.
Yes.
Thank you so much, expert panelists and chairpersons.
Wires are more difficult to reuse. And by the way, there's a new rotor wire called, anyway, we'll discuss that in the
the Rota X.
Yeah. Rota thing.
Much more talkable.
Yeah.
Thank you.